Oh, coming soon. I have to change that. Okay, it's out. So as of yesterday, the Chrissa Borel is available. So this is the first of the phosphodiesterase 4 inhibitors. And there are others that are in development, in trials, coming soon. Have no idea if they'll be better or not than what this is. But this is something that's been touted as a unique boron-based formulation, which supposedly helps to make it get through skin better, be more potent. But you know, we'll see when it comes out what happens in terms of utilization. We know from the topical calcineurin inhibitor story, when the articles came out in 2001, we found out so much more about how they could best be used when they were on the market, and we really had a lot more experience. In fact, unfortunately, the studies showed that in children, 0.03 was just as effective as 0.1, which the minute it came on the market and we had all of our 0.1% kids in studies go to 0.03, we realized that that wasn't true. So at any rate, we'll learn a lot more once it's out on the market, but just a reminder that PDE4 increases have been known for a long time. John Hannafin was looking at cord blood, in the 80s at some point. So we've known that for quite a while. And the way that this works is by increasing cyclic AMP and reducing inflammatory cytokines. And the studies, the two pivotal studies, basically were both statistically significant. You know, these typical high vehicle rates that we see with most of the atopic dermatitis trials. But nevertheless, this was in a patient population from mild to moderate disease as low as 2 years of age and up into the adults. So this will probably be an alternative to topical steroids for these milder patients. So far, there's been no clinically important safety signal, so at least it looks safe. And it doesn't have the baggage of the calcineurin inhibitors. So quickly, next steps for non-responders, thinking about contact allergy reactions, especially if you see face and hand dermatitis that seems to be recalcitrant for what should be appropriate treatment. And these can be emollients, some of the cleansers people are using, even the topical steroid, and we always have to think about fragrance as well. I love this picture. I'm so sorry. This is a picture from Sharon Jacobs of a kid whose mother just couldn't get the face clear, and she was even cleaning it all the time. Well, she was cleaning it with baby wipes, which of course have all kinds of things in it, fragrance, propanol, but also MCIMI, which of course is one of the hot, newer contact agents, and was an issue in this case. And don't forget that extensive dermatitis can also reflect airborne allergens, these exposed areas, or even systematized reactions. Big thing for me is thinking about infection. So many kids come in who aren't responding because they're infected. And they really need not only the antibiotic, but a regimen to maintain better control with respect to that. Now, we all know a lot of patients are colonized. See some different numbers, but nevertheless, up to 90% with Staph aureus. And it's not just on the skin, it's in the nares as well, of course. It's under the fingernails. And we think that this relates to the fact that there are these decreased innate immune responses, poor barrier, filaggrin being down, which I just showed you is not an early problem, proteases being up, can't tell you if I know that, decreased antimicrobial peptide, and I think the verdict is still out in kids with atopic dermatitis on that. I will tell you that antimicrobial peptide expression is much, much higher baseline in children than it is in adults. And atopic dermatitis patients who are these young kids have just as high or higher of that. But again, we don't know whether it would be much, much higher. So we're starting to look at that now in other disorders. MRSA, a growing concern. These are the hardest patients to manage, very difficult, but certainly not above the MRSA that's in the general population. In fact, there's some evidence that there may be, relatively speaking, a lower risk of MRSA, maybe because of competition with MSSA that's on their skin. The microbiome studies are fascinating. Heidi Kong's beautifully shown the reduction in normal flora with flares and an increase then in Staph aureus. And what's interesting to think about is how much of a problem the Staph aureus is, which we know produces exotoxin, a variety of different enzymes that can impair the barrier, that can trigger the immune system in ways that exacerbate atopic dermatitis. Or is the problem the decrease in the diversity that's seen? And Rich Gallows had some very exciting work showing, for example, that Staph epi produces products that combat Staph aureus and group A strep. There's been work as well in atopic mouse models showing that epicutaneous application of non-pathogenic bacteria reduces atopic dermatitis inflammation. And of course, we've got in other areas literature about, for example, for clostridial infections where we have pseudomembranous colitis. We know that you can give back stool to people and that helps, and they're doing that now for food allergies even. So stay tuned. There will be studies coming out looking at non-pathogenic bacteria applied to skin and seeing if that makes a difference. But in the meantime, we have an easier way to at least try to help with the increase in staph, and that's with bleach baths. And this has become really standard of care for kids with atopic dermatitis, where we put in what's the equivalent of about a half a cup if it's a full tub and standard tub, and a fourth of a cup if it's a half a tub. And when we think about the tubbies, I tell parents to take a milk gallon, gallon thing of milk and try to figure out how much water they're putting into them, and then figure it out from there. And it's about 4 cc's or 4/5 of a teaspoon per gallon, or about 1 cc per liter. And I, by the way, do hand and foot soaks too, because I find those are the most difficult areas. But we did a study many years back, I think everybody's familiar with it, just showing that in these moderate to severely affected kids who came in with an infection, we were able to put them on a cephalexin and at the same time randomize them either to get plain water or bleach poured into the tub, and at the same time we stuck either mupirocin or a vehicle up the nose. And what we saw clearly was an increase. We weren't looking at bacterial numbers, although we cultured in eczema severity and in using the EASY score in body surface area that was statistically significant at 1 month, and at 3 months, a very statistically significant difference. And when we tried to ask the question, well, is it what's in the nose or is it in the bath, we found that because with the EASY score we were able to look at certain body areas, it was the areas that were submerged that showed that difference in terms of with or without the bleach, and not in the exposed areas. And that allowed us not only to realize that it really is the bleach bath, but also tells us that we got to take a little soft cloth and get it on other areas as well. Now, when we kept culturing, it didn't clear up the Staph aureus. Some we weren't able to culture from, but others was right there. And this is a reminder that we're not getting rid of it. In fact, it's not even clear yet, because the studies aren't out, what happens to the microbiome. Although there was one study presented in abstract form at the SID suggesting that it goes back to the non-lesional skin microbiome. But regardless, this is really a maintenance, and that's what I stress with my patients. I don't even care if they use it at the beginning when they start for infection. In fact, I often tell them wait 5 or 7 days on the antibiotic, and because the skin's often raw, I don't want it to be uncomfortable. It is maintenance, and I stress from the very beginning, this is something that you're going to continue to do all the time. There are some bleach antiseptics that you can use in the shower, so for the older kids, they're not inexpensive as opposed to the bleach, which is really cheap. And by the way, not the ultra concentrate ones, but the 5 to 6% bleach. It's important to stress that. But you can use those, and they have also shown some value, these antiseptics that you can use instead of the wash. The leave-on ones have shown some value too, but I think those remain to be seen in terms of how much. Now, what I think is fascinating is the question of how much of the effect on the severity of the atopic dermatitis is just from the reduction in bacteria versus a direct anti-inflammatory effect. And this was some work from Thomas Leung, where he found in cultured keratinocytes that adding this percentage of sodium hypochlorite reversibly inhibited NF-kappa B signaling, suggesting a direct anti-inflammatory effect. And then he was able to look at a model, including a radiation dermatitis model, in which he reduced the inflammation in that model through compressing. A word about MRSA. I again find that much more difficult to deal with, and what really helps for me is reducing the environmental Staph aureus load. Now, Mike Cork never published this, but several years back at an international meeting, he had a poster in which he had looked at swabs of bacterial cultures from the rims, the nozzles, the containers of preserved and unpreserved products that were going on the skin, emollients and topical medications, and he found 53% of them were contaminated, 25% of them had Staph aureus. And if you think about it, you know, you go into your tub of topical and you put it on the skin, and then you go back in and get, I mean, now you can get a vivid image of those bacteria just transferring, and then you just keeping them sitting on a shelf. It's also been shown that nasal carriage of the same Staph aureus strain is seen in 65% of parents of children. And I love the studies of pets, because you can culture up the pets in the family and find the same bacteria, including MRSA. So some of the recommendations that I make are, first of all, if I don't do this to everybody, but when we're really struggling, keeping the moisturizers in the refrigerator and then floating them in the tub so they warm up. Pump or pour bottles rather than jars if that's available. Avoiding direct contact with the hands, so using the plastic spoon or whatever to take it out and keep changing that every time you go back in. Avoid sharing personal hygiene items within the family. And when I'm dealing with MRSA and I'm having trouble, I decolonize everybody. So I get the whole family, not just sticking up the mupirocin 5 days in a row once a month, but in those bleach baths. And I tell them the same thing. If they're often using the same moisturizers in families, things like that. So you got to think about it. I will say for pets, I don't put them in a bleach bath. Now, somebody raised the question, well, they can go in swimming pools. They seem to be fine. Okay, so maybe it'll be okay. But I still feel better telling the family to talk to their vet about how they should do that. A minute on systemic immunosuppressants. Again, we sometimes do have to go to that. We have to weigh the risks and benefits with the family. And in kids, there's really nothing out there in terms of comparative trials, detailed treatment guidelines on this. I will tell you that we did a survey recently and found that among the systemic agents used, cyclosporin was used most commonly as first line, followed by methotrexate and mycophenolate mofetil in the United States. Phototherapy would be great, except that most of our patients can't comply with it. They can't get to phototherapy. It's hard to get booths at home. It's hard because you've not only got the parent's schedule, but you've got the kid's schedule, which is often horrendous. So I find it very difficult to do that. And of course, if they're very inflamed, it's not the way to go. Corticosteroids, we tend to virtually always avoid in kids. There are a few times when, unfortunately, they're put on them, and they usually have rebound, and they're certainly not practical for continued use. Now, there are lots of things coming out. This is a list of phase 1, phase 2, phase 3. Of course, nothing in children comes first. They all have to be tested in adults. And I think everybody here knows that the one that's in phase 3 and, hey, maybe coming out in the next month is dupilumab, which is pretty exciting because of the fact that this is really targeting that Th2 process. Results look good. It's, of course, directed against the human IL-4 receptor, which is the receptor for both IL-4 and IL-13. And in the phase 2 trials, the results looked very, very good in terms of versus placebo. And there have been studies both with rescue, with topical steroids and without. With topical steroids, you're getting easy 50 scores of 100%. So really a very exciting